Thank you.
I am Paul Grippo from the University of Illinois Chicago, Associate Professor of Medicine in the GI Division. I'm also the Associate Director of Career Enhancement Education for the UI Cancer Center. And I want to welcome everyone today for a very interesting talk by a well-advanced PhD student, and we'll get to that in just a minute. I'm going to share my screen so we can go through a few slides here. And please let me know and see what I have here. Let me make sure I get it in presentation mode for you. Does everybody see? Yes? Okay, very good. So I'll be brief just to make up for the little bit of time that I stole from you already. Apologies for the technical difficulties. Statement of purpose, I won't read this, but of course, I think we all have common interests in regards to the technology for measuring areas of hypoxia from a variety of different angles. I come from more the tumor angle, which is very interesting, but of course, it would have application in a variety of ways. So I'll leave that up there for just another few seconds, just to make sure that we're kind of all on the same page in regards to what this seminar series offers. I do want to make sure that everyone's informed about upcoming events. This is an event that will be happening on June 6th of this year. Dr. Pagel from MD Anderson will be looking at how EPR technology and imaging is used for evaluating the tumor microenvironment. So certainly something very applicable to the work I do and perhaps others focused on. And another event that's going to be happening sooner would be May 2nd. This is a group from Duke that does a lot of work with radiosensitization and therapy, and again, a sarcoma condition. And they're, again, the idea of using the technology to follow the progression of that as it occurs. Right into top, and I'm pleased to Ina Gertsenshteyn, and I apologize if that's not the correct pronunciation. I was working on it earlier. Close, but you can correct me, Ina, in that regard. She's a graduate student at Chicago, and about she's currently co-mentored by Doctors Halpern and Chen. And I'm hoping you can still hear me. I have a little message here that my internet is unstable. And she actually started her work prior to working as a graduate student. She was working in company, as you can see, in regards to imaging technology. So she's got vast experience coming from the workplace and then jumping into her PhD program. I think that's a very unique way. And by the way, if anyone else you want to put your, make sure you're on mute so we can all hear everything. Make sure you're on mute, please. Thank you. Anyway, what I found very interesting is not only is she finishing up her PhD, she is now working as a co-op at Biogen, and she can maybe talk a little bit about that. I think that's incredible to be able to do all these things. So she's juggling many things, and she really has a nice record. Some of her publications, which aren't listed here, are worthy of note. And you know, when someone comes from industry and comes in to get her PhD and then is expanding horizons and now is considering a postdoc or again doing a co-op with another company, shows great fortitude. Ina, it's a pleasure to meet you. And again, I'm going to just thank you for your time and effort, and we look forward to hearing about your data. And you've got the next 40 plus minutes to let us know what you've been doing for the last several years. Thank you for joining us.
Thank you very much, Paul. That was the nicest introduction I've ever gotten. Okay, I'm just going to share my screen. Can everyone see the slides and hear me okay?
Yes, we do.
Okay. Yeah, so my name is Ina Gertsenshteyn. Paul did a fine job pronouncing it. And I'll be presenting our work on oxygen-guided radiation therapy, comparing EPROI and FMISO PET for hypoxia imaging. I'd first like to acknowledge everyone at O2M and the University of Chicago. I'm not doing all these experiments by myself. It takes a lot of people. So thank you everyone in the EPR, MRI, PET, cyclotron, and immunohistochemistry lab. And of course, thank you to all our funding sources. So even though what I'm presenting today is mostly our results on preclinical studies, our overall goal is to increase the survival probability of patients with hypoxic tumors. Tumor hypoxia, as I'm sure everyone here knows, is associated with poor patient prognosis. Hypoxia increases the risk of metastasis and resistance to therapies, and it can get tricky because the hypoxic status of a tumor is independent of its size, stage, grade, or histology. So without the right functional imaging or biomarkers, you might not know whether a tumor is hypoxic or not. And hypoxic tumor cells become resistant to radiation, so this reduces the effectiveness of radiotherapy, and that's what we're focusing on in the Halpern lab. You need a higher radiation dose to decrease the hypoxic tumor cell survival rate, but this higher dose can also harm healthy tissue around the tumor, so we need to strike a balance between delivering a higher dose to the hypoxic, more resistant tumor regions and deliver a lower dose to oxygenated, more sensitive tumor regions. And that would maximize the therapeutic index, which is the ratio between 50th percentile of toxic dose and effective dose. And you want that ratio to be as big as possible. So here we're evaluating the effectiveness of oxygen image-guided radiation therapy with electron paramagnetic resonance oxygen imaging, which I'll just call EPR from now on, in preclinical studies. A very high-level view of all this work is that we're using dose painting to deliver a radiation boost to hypoxic tumor regions and comparing treatment outcomes to an oxygenated boost treatment to a control set of tumors. And we're comparing local tumor control in 3 murine models, and we're also comparing treatment results between 2 different EPR machines, our 250 megahertz EPR imager, which I'll call the LF-EPR, and then the 720 megahertz EPR imager, the Jiva25, which is a product of O2M. Okay, that's about the chat. I will also talk about my dissertation, which is evaluating multi-modal tumor hypoxia imaging so that we can compare EPR with FMISO PET. Because if you go back to our goal, we want to increase survival probability of patients with hypoxic tumors, and FMISO PET is, at the moment, a more clinically available imaging modality than EPR. Doing a quick comparison of hypoxia imaging between EPR and PET. They're both non-invasive modalities for in vivo hypoxia imaging, but at the moment, only FMISO PET is widely available for clinical studies, and there are past and ongoing clinical trials using FMISO right now. Because of how the tracer is distributed throughout the tumor, EPR has the advantage in acquisition time. It doesn't take long for the spin probe to diffuse through the tumor and take an image, maybe 5 or 10 minutes. While FMISO PET, you have to wait 2 to 4 hours after injection to start getting, for the MISO to start binding intracellularly to hypoxic cells. EPR also has an advantage in spatial resolution, got about 1 millimeter resolution, while scanner resolutions for PET can go up to 5 millimeters, maybe 6 in clinical PET imagers. But it's a bit better in preclinical, which is what we're dealing with today. So for the rest of this webinar, it'll be divided in 2 parts. First is our results in oxygen-guided radiation therapy with EPR, featuring Jiva25. Our studies just completed 2 weeks ago, so this is going to be brand new information. And then the next part will be comparing tumor hypoxia imaging with FMISO PET and EPR. And then at the end, we'll have some time for questions. But I also want to highlight how many modalities we have for a single tumor. So at the top are our hypoxia images with FMISO PET and EPR. Hopefully you see this pulsing white contour showing hypoxia in both modalities. We also have T2-weighted MRI, where we can contour the tumor. And K-trans and VE are, K-trans is looking at the perfusion and permeability of tumor vasculature, and VE is looking at the fraction of extracellular, extravascular space. These come from DCE-MRI, which I won't talk about too much today, but we also have data on that. Okay, part 1. I think everyone here is very familiar with EPR, but just in case anyone isn't, very high-level explanation, we have an oxygen-sensitive spin probe that we inject through the tail vein, give it some time to diffuse through the tumor. And in this spin probe is an unpaired electron, and we take advantage of this similarly to MRI physics, where you have a radio frequency pulse and you watch the relaxation rate of the proton spin. We're doing something similar but looking at unpaired electrons instead, because of their relationship between relaxation rate and surrounding pO2. So using this relationship, we can reconstruct a 3-dimensional oxygen map of the tumor, where in this color map, all these dark blue spots here are considered hypoxia because we define hypoxia by pO2 less than 10 torr. So you can see this particular tumor has a heterogeneous spread of tumor hypoxia. So it's important to accurately be able to see this if you're doing something like targeting hypoxia for boost radiation. There's a very linear proportion, or the oxygen-sensitive spin probe's relaxation rate is linearly proportional to the partial oxygen pressure, or pO2. You can see these very tight error bars, and I want to point out that we are measuring the spin lattice relaxation, or R1, because it's independent of the spin probe concentration. Quick plug for the Jiva. It used to be in our sub-basement. Now I don't know where it is, but I think there's one available now. It's got software already built into it, so you can do all your image acquisition, reconstruction, registration, and analysis right on this machine. You don't need any cooling because these magnets are on the order of millitesla. So it's got a relatively small footprint. It's shorter than me, and I'm 5'3". It's very fast and precise. You get 1 torr oxygen resolution, imaging time takes less than 10 minutes, sub-millimeter spatial resolution, and in the Halpern lab, we mostly use it for in vivo animal experiments with mice, and 1 image takes 5 minutes to acquire, but this is also suitable for measurements in vitro. Moving on to looking at our data, we primarily use 3 tumor types: FSA fibrosarcomas, MCA4 mammary adenocarcinomas, and SCC7 squamous cell carcinomas. These all have different tumor growth rates. FSAs grow the fastest, MCA4s grow the slowest. But these are all syngeneic tumor mouse models that we grow into the leg of C3H mice through an intramuscular injection. And as you can see by these H&E slides, the features of these 3 tumors are quite different. And some things we've noticed are that FSAs have a higher instance of necrosis, and there's an inconsistent tumor cell density throughout these tumor slices. MCA4s are very messy. There's a lot of stroma and collagen throughout the tumor, and there are large vascular structures within the tumor, while SCC7s are very densely packed tumor cells and dense microvasculature. And I think this is a snapshot close to the edge of the tumor, and you can see the tumor cells taking over the muscles. We have 4 groups of data. We have 54 FSAs, 48 MCA4s, 48 SCC7s, and all of these were imaged had oxygen images acquired in the LF-EPR. Then we also have 40 SCC7 tumors with images acquired in the Jiva. And as you can see, there's not really any relationship between tumor volume and hypoxic fraction. So you can't really predict how hypoxic or normoxic a tumor is going to be. So we wanted to make sure that we had similar or not distributions of hypoxic fraction and tumor volume in these 4 groups. And for some reason, the SCC7s imaged with LF-EPR had a higher hypoxic fraction than the rest. And That just is what it is. I don't know why that happened. Tumor volume was highest for FSAs. I think that's just because of its faster growth rate. And then I also looked at experiment duration to see if the time between EPR image acquisition and treatment would affect results. It ended up not. And the reason that these experiment durations are so different across groups is just because of the number of research technicians that we had at the time. So I think for FSAs, there were 3 or 4 people, but later on, there were only 1 or 2, and then COVID really slowed things down. But overall, experiment duration does not have an effect on treatment. We also saw that there are comparable tumor characteristics between treatment groups for the 2 different treatments that they can get, either a hypoxia boost or an oxygenated boost. So looking at the hypoxic fraction, tumor volume, growth rate, and experiment duration were mostly totally comparable, except for MCA4's, slightly different experiment duration between 2 treatment groups. But again, this ended up not affecting results. Going into the experimental design, we have 3 main parts. First, we have to do tumor control dose experiments for each tumor type, because we treat the whole tumor at 20% of the tumor control dose and then deliver a boost at around 95 to 99% of the tumor control dose. Once TCD experiments are done for a particular tumor type, we start imaging and treatment. So we have 3 modalities. First is T2-weighted MRI, so that we can contour the tumor and check that it's within a predetermined range to continue the study. Next, we do EPROI, calculate the hypoxic fraction within the tumor, and again, check if it's in a predetermined range. And if it is, we move on to CT imaging, which is done in the XRAD, and that's the same machine as we use for treating the tumor. So all of these images are registered to the CT space for part 3, which is treatment, where we deliver a whole field dose to the whole tumor, and then a boost dose to either the hypoxic boost treatment or the oxygenated boost treatment. And mice are randomly assigned to one of these groups. Then we track local tumor recurrence and make sure that the animal is doing well. And once the study is complete, after a mouse has been in there for 90 to 180 days, depending on the tumor type, we look at local tumor control for both treatment groups using Kaplan-Meier survival analysis. These are the actual tumor control dose curves. So in black are the FSAs, and you can see there's a lower tumor control dose. We only need a whole field tumor dose at 22.5 gray. And then the carcinomas had a higher tumor control dose, so they needed to be treated at around 50 gray. And as you can see, the slopes of these curves are relatively similar, and they all ended up getting a 13 gray boost. Here's an example of what images look like for one of these tumors. This is all the same tumor. You can see it here in T2-weighted MRI. The tumor comes up pretty clearly with these brightly colored voxels, while the muscle has darker tissue. And we also have fiducials for registration that are filled with water and the oxygen-sensitive spin probe, so it also comes up in the EPR image. Within the registered tumor contour, we see hypoxia inside the tumor, while outside the tumor remains well oxygenated, as we would expect. And then here's the CT, where you can see the leg cast in the bed that we use to immobilize the tumor-bearing leg so that it doesn't move across these different imaging machines. And we make sure that everything looks in place before we start treatment. So for the dose delivery plan, a mouse would be randomly assigned to either a hypoxic boost or oxygenated boost. And this is an example of what that treatment area might look like, depending on which one it was assigned to. So in red is the projected hypoxia outline of the hypoxia in the tumor that we would see along a treatment line like this, for example. And we also look at hypoxia that even is just like a little island so that we can treat as much hypoxia as possible. So this would be in gray at the corner here. This would be where we're delivering a boost. The hypoxia avoidance boost dose plan would be delivering a boost around that hypoxic region. But in the end, no matter which treatment the mouse gets, it would receive a similar overall dose deposited to the tumor. And these are examples of tungsten-loaded plastic blocks that are 3D printed to shape that conformal dose. So here would be a boost treatment block where that extra 13 gray boost is going right through, but around it, the dose is attenuated, while this is an oxygenated boost plug, and the hypoxic region is blocked out, so that would be attenuated, while around it, that extra 13 gray boost would go right through. Moving on to the results, we found that in 3 out of 4 of these groups, hypoxic boost treatments resulted in significantly higher local tumor control probability. So starting at the top are FSAs and MCA4s. You see that the local tumor control probability was significantly higher for these hypoxic boost treatments, which are these solid blue lines, while oxygenated boost treatments, these dashed red lines, had a lower local tumor control. Looking at the SCC7s, these are kind of weird. For some reason, the SCC7s imaged with the LF-EPR, we did not really see any difference between hypoxic boost versus oxygenated boost treatment, even though hypoxic boosts had a slightly higher local tumor control. But when imaged with the GIVA, you can see there's a huge difference in higher local tumor control for hypoxic boost treatments versus oxygenated boost treatments. So I'd be happy to discuss this at the end if anyone has any ideas. I have 2 ideas of what's going on here. One is that we have better oxygen resolution and a higher SNR with the in the GIVA compared to the LF-EPR. So maybe our hypoxia maps are more accurate and our conformal dose plugs are more accurate. So we're seeing better results there. Another possibility is that dose painting is just wouldn't work for more hypoxic tumors, because if you recall, our hypoxic fraction distribution for these two, the SCC7 tumors imaged with the LF-EPR, had a higher hypoxic fraction than the other treatment groups. So this might there might be other biology at play that we need something more than just a boost to hypoxic regions for these tumors. I'm leaning towards the hypoxic fraction theory because when we stratify these survival curves by low or high hypoxic fraction in the GIVAs, you can see that tumors treated with a hypoxic boost in blue that had a low hypoxic fraction had a 90% local tumor control probability, while the tumors that had a higher hypoxic fraction but were still treated with a boost had less than 50%. So I think at least definitely for SCC7s, hypoxic fraction plays a big role in tumor control. Experiment duration and tumor volume did not really have such a dramatic effect as we see here. Looking at SCC7s imaged with the LF-EPR, I'm hesitant to make any serious conclusions because all these endpoints are so similar, but the two highest probabilities are tumors that had the low hypoxic fraction. But again, there's no significant difference between treatments here, and not for experiment duration or tumor volume. And then, to confuse things even more, we saw the opposite with MCA4s. A higher hypoxic fraction with a hypoxia boost delivery had the highest local tumor control for both mammary carcinomas and for fibrosarcomas. And we saw this effect most dramatically with the fibrosarcomas. So it really looks like hypoxic fraction plays a big role in all these situations, but it's tumor type dependent on which way, if you want a higher or lower hypoxic fraction. So to summarize these results, EPROI guided radiation therapy does show potentially enhanced therapeutic index from dose painting across tumor types with an asterisk. In FSAs, MCA4s, and SCC7s, EPR can definitely define tumor hypoxia and boost hypoxic tumor subregions and increase local tumor control. But some tumors, especially SCC7s, that have a large hypoxic fraction may not be suitable for dose painting. So this is really important for us to know, especially for clinical trials. People need to measure the hypoxic fraction of a tumor and decide maybe a localized boost is not appropriate. If the hypoxic fraction is too high, maybe you would need to boost the whole tumor. Our future work in this part is to make oxygen image guided radiation therapy more clinically relevant, even with our preclinical studies. So we have a publication on small animal IMRT using 3D printed compensators in more than 2 angles at opposing beams, using 3 or 5 angles like they do in humans. We're also trying to improve tumor hypoxia location with FMISO PET, DCE-MRI, and EPR. And we've also developed a hybrid PET EPR combined imaging system for assessing tumor hypoxia. And this machine that came from this development is what most of my research is that I'll talk about right now in part 2, which is comparing tumor hypoxia imaging with FMISO PET and EPR. So as I mentioned in the introduction, FMISO PET is clinically available for hypoxia imaging. Here's an example of a mouse with an MCA4 tumor imaged in a molecube system. And here's the FMISO accumulated in the tumor 2 hours post-injection. You can also see a time series over 2 hours of how first the tracer is distributed through the body, and then after some time, it starts to accumulate in the tumor and then focuses in on the hypoxic region. I want to also share a couple of examples of recent clinical studies using FMISO PET and how that affects radiation treatment plans. So this is a study in Germany with head and neck cancer, and they compared outcomes of treatments of tumors that did not have hypoxia and tumors with hypoxia that got standard radiation therapy. And they also had a group of hypoxic tumors that got dose escalation by 7 gray. And they found that local regional control did improve for hypoxic tumors that had dose escalation, 70% versus 44%. But in the end, the disease-free survival was around 40% for all hypoxic tumors and around 100% for non-hypoxic tumors. Another phase 2 study from France, looking at patients with non-small cell lung carcinoma, had similar results. They had 3 groups. One, this red group, where the tumors did not have FMISO uptake, so they were normoxic. And then tumors that were hypoxic and did not receive a boost versus tumors that were hypoxic and did receive a boost. In both cases of overall survival and disease-free survival probability, patients without hypoxic tumors did the best, while in the end, there wasn't such a significant difference in disease-free survival probability between boosted or not boosted hypoxic tumors. There's a very new study that came out showing how FMISO can be used to identify patients that would benefit from dose reduction by 40 gray, where they had 94% local regional control and survival for patients that did not see hypoxia and only got 30 gray delivered instead of the 4 patients that did have hypoxia and were treated with the standard treatment of 70 gray. So this is a very good use of FMISO to reduce toxic side effects from too much radiation. So I'm talking about all this to highlight the clinical advantages to imaging tumors with FMISO PET, but also, the dose escalation targeting the tumor subregions that had high FMISO uptake didn't really go as well as hoped. I think it's for 2 reasons. One is that I don't think FMISO is as accurate as EPR for many reasons. Someone's not muted. And then another reason is that there's no optimal threshold to define hypoxia, even across the same tumor types. So some groups may not be using the right threshold to define hypoxia, and as a result, their dose plans may be suffering. So for example, these are some studies I found of kind of dose escalation studies or de-escalation studies, trying to target tumor hypoxia for radiation treatment, and they're all using a different threshold or not even specifying what their threshold was. This review from the British Journal of Cancer also looked at tumor to reference tissue ratio thresholds across all of the PET hypoxia radiotracers and all the tumor types that they could find. And again, there was no consistent threshold. So part of my work is to use EPR to calculate the optimal FMISO PET threshold to define hypoxia. And we can do this with our hybrid PET EPR imager. The EPR operating frequency happens to be the same as in the JIVA, 720 megahertz, and which you can see here, these brown magnets. And then inside is the PET insert that's also compatible with MRI. And the main advantage to this is that the mouse and its tumor are in identical physiological and physical conditions. So we're not having to move it, we're not spending a long time between modalities to image the same thing. So we can use EPR pO2 voxels as the ground truth to define tumor hypoxia while we look for the optimal PET threshold. Looking at the time, I'm going to go a little quickly here, but this is an overview of the data. In all, we have about 30. And this is the study design where we make FMISO at the cyclotron at UChicago, inject 230 microcuries of FMISO, and then we wait 2 hours before we image EPR and PET, because again, it takes at least 2 hours for the FMISO to bind to those hypoxic cells. Then we take the mouse to MRI for T2-weighted MRI and DCE-MRI. And these are just examples of 2 mice to show you how different every tumor can be. These are both SEC7 squamous cell carcinomas. One of these tumors has like a big hypoxic core, while this other tumor has less hypoxia in these throughout these 3 nodules of the tumor. Our analysis protocol: first we pre-process the data, register and resample it all into the same space. And then I'll mostly focus on this part, which is finding the optimal FMISO hypoxia threshold, using EPR as the ground truth. I'm also doing work in comparing correlations between tumor hypoxia with DCE-MRI and validating our in vivo images with H&E and IHC. And all of this work is going towards developing a machine learning algorithm to improve tumor hypoxia location with PET MRI to make these more clinically accurate and available. So we use ROC analysis to find the optimal hypoxia threshold. Let's spend a little bit of time on this plot here. This is a scatter plot of all the voxels in one tumor, and each voxel, each point here corresponds to some value of pO2 from EPR and some FMISO uptake value. Based on EPR, there's a hard line defining hypoxia at 10 torr, so everything to the left of this line is considered hypoxic. And then depending on where we move this horizontal line to define hypoxia with FMISO, the true positive fraction and true negative fraction might change. So as we sweep along this vertical axis, we are getting different values of true positive fractions and false positive fractions in this ROC curve. Ideally, we would have a true positive fraction of 1 and a false positive fraction at 0, but of course this doesn't happen. So this red line is the mean ROC curve of all the SCC7 tumors. So you can see, like, you can overestimate hypoxia and you get a really high true positive fraction, but also a very high false positive fraction. So we need to find some sweet spot. Here's an example of one tumor with hypoxia defined by EPR in blue, and then how hypoxia can look with FMISO PET, and it can look different depending on threshold you use. So we need to find the best one, or the one that has most similarity with EPR. And choosing the right FMISO threshold impacts over or underestimating hypoxic fraction, which can really affect treatment design and outcome. In the interest of time, I won't go into this, but basically for each potential FMISO threshold to define hypoxia, we need to calculate the similarity of where hypoxia is found in the EPR versus the PET image. And we want our similarity to be as close to 1 because that would indicate perfect overlap. And if it's 0, there would be no overlap. So we calculate this, the Dice coefficient, Hausdorff distance, and accuracy for every potential threshold in PET, keeping true hypoxia set at 10 torr. And we found that the maximum overall hypoxic overlap is found with these two thresholds, SUV greater than 1.4 times the mean, and SUV greater than 60% of the max. So for SCC7s, we would, based on this work, we would recommend defining hypoxic voxels with these thresholds, and they are within the range of other reported thresholds from the literature and other clinical trials. And we're still collecting data on MCA4s and FSAs to repeat the study, but so far the results are very similar to these. Also, the generally low overall hypoxia overlap between PET and EPR images confirms the inaccuracy of FMISO PET and the need for a correction. And then how much time do I have? Got like 5 or 10 minutes left. So quickly, I'll just go through some side projects like validating in vivo images with IHC. We take sections that include the tissue around the tumor so that we can register them to our in vivo images, like our MRI, and we can find the place within the tumor. And we have these sister sections every 500 microns of H&E, HIF1 alpha, and CD31 stains. HIF1 alpha can help us locate the tumor and look at areas of necrosis. HIF1 alpha is the hypoxia-inducible factor, and mostly in these tumors we saw higher HIF1 alpha expression in the nucleus around blood vessels and somewhat around necrosis, but not always. And then CD31 stains blood vessels in the tumor. We can threshold features in these IHC slices to quantify features like HIF1 alpha density throughout a slice or blood vessel density throughout a slice, and then register these to our in vivo images. So for example, we can compare within regions of interest, the hypoxic inducible factor density compared to pO2 through EPR, or HIF1 alpha density of FMISO uptake. We see a very strong correlation between EPR and HIF1 alpha density, and a moderate correlation between FMISO uptake with HIF1 alpha density. And we also saw a very strong correlation between blood vessel density and K-trans, but surprisingly, absolutely no correlation between blood vessel density with pO2 from EPR or FMISO uptake. And then ongoing work is developing a machine learning algorithm to make FMISO PET more accurate in locating tumor hypoxia by combining features from PET and DCE-MRI. I have to finish this work soon because I'm hoping to graduate this summer. So, but because this is being recorded, I don't want to show preliminary data. And some final thoughts. There is potential for oxygen image guided radiation therapy to increase local tumor control of hypoxic tumors, especially with companies like O2M. We have the JIVA for preclinical imaging, and they received a grant for the Cayley to develop a human oxygen imager prototype. So there's great work being done to advance this work. I'd like to acknowledge everyone again, and thank you everyone for attending. And I'd be happy to answer any questions or just have a discussion.
Thank you, Mina. Very nicely done. I'm going to pause here just to give folks a chance to come up with questions. I have a few questions of my own, but I don't want to be too selfish here. So I'll give you a few, well, maybe not a minute, but I'll give you some time just to, again, at this point, no need to use the chat. You're welcome to take yourself off mute and ask any questions you may have.
So, Hal Schwartz, what is the rationale? I would have thought that you would have compared the boost to the hypoxic without the boost. What's the rationale of using the boost to the oxic versus the boost to the hypoxic?
It just serves as a control because the overall dose deposited in the tumor and the overall volume of radiation is similar between the two treatments. I think this is looking at how accurate EPR is in locating hypoxia, because if it was just about, oh, can you deliver radiation boost anywhere in the tumor, then we wouldn't really see a difference in these two tumor types. I did do comparisons of with our tumor control dose data where we did deliver to the whole tumor. I did do some comparisons there. And there is comparable, I should have shown those slides. There is comparable local tumor control probability of like a 70% tumor control dose and a boost. We should show those in the future, but that does show that like overall, you're trying to minimize the overall dose to spare organs at risk around the tumor. So in that case, the boost might be better than to the whole region.
The idea was that you wanted to, in both groups, show equivalent integral tumor dose, so that the tumor dose can't be blamed, the total integral dose to the tumor can't be blamed for the increase in local control.
Thank you, Howard. That was Howard Halpern. I'm sure everyone knows him, and he designed all these studies.
Hello, Ina. This is Ben Williams out at Dartmouth. Kind of a follow-on question with the models. I think this probably may not be the best model to look at this in, but did you notice any differences in the toxicity between those two groups?
I don't think so, no. All of the tumors had to be treated for dermatitis, but I think like the side effects from the mice were similar in both treatment groups. Does that answer your question?
It does. It does. I was thinking about the Memorial Sloan Kettering head and neck trials where toxicity is one of the main drivers going ahead toward human studies. But this is fantastic. These are things that students of Howard's like me have been dreaming about for years. So fantastic work.
Thanks. Just for the record, I wasn't, there are a lot of people going behind all this work. It's not just me.
Let me, one clarification that should be made here is that these treatments were opposed apertures, okay? And so that it was basically 1980s type radiation that we were delivering. And there was very little attempt at doing modern intensity modulated radiation where one could really focus dose either on or away from the hypoxia a little more selectively. And that's the sort of the next set of experiments that we're going to be doing, as Ina alluded to.
We also did tumor control dose studies in fractionated deliveries. I should have mentioned that, but that also is also something we're doing.
Well, I'm going to jump in and ask a couple of questions. One's more technical, and it may not be relevant, but I'm going to ask it anyway. You mentioned using DCE-MRI, and I would assume that includes an injection of contrast agent. Using the other modalities, whether it's the, and I apologize, I think the PET imaging or the O2M, the EPR. Do you think that the contrast would that alter the imaging or any of the technical aspects involved when you kind of layer your technologies? I know you have like 2 or 3 in one box.
So that's why we do EPR imaging before DCE-MRI. It's because the gadolinium you can't do EPR imaging after you inject gadolinium.
Okay.
It does not have an effect on PET.
On the PET.
Mm-hmm.
Okay, so that's why you built your MR PET kind of together, because you could do it almost like one right after the other, right? Is that?
Yeah.
Okay.
We first go on.
And then more importantly, to the biology or the pathology, do you think that the O2 pressure you talked about, like the real nice, bright, kind of almost reddish color with like 60, was it torr of pressure?
Torr millimeters of mercury.
Torr millimeter, right. So do you think that correlates with greater areas of desmoplasia? In other words, we talk about certain tumors like ovarian and pancreatic that have extremely dense stromal beds in some cases, which again would serve well for being hypoxic regions. Do you think there's a correlation there? Is there a way you could measure that or determine if that association is for real?
A correlation between pO2 and what? Sorry?
And a real dense stroma. The stroma kind of, same way, like when you show these hypoxic regions, I look at it and go, boy, we've been able to look at least in pancreatic tumors, areas that are really, dense in the stromal or even in matrix composition, and then other areas where it's more relaxed. And again, this has been done elegantly with pressure readings and other types of readings. So I'm just wondering if there's a correlation between hypoxia and maybe these, more dense stromal areas.
That's a really good question. We won't know how stromal the areas are just with MRI and EPR. We need to do histology on it. So those plots of pO2 versus HIF1 alpha, those were done on SCC7s, and I haven't done that work yet on these mammary carcinomas where you do see all these stromal structures. So that is a good idea for me to do next, to see if I can threshold out all these structures and see if there's a correlation with more dense structures like that and pO2. So
you've got outstanding,
I don't know, but I can find out.
Sure, and you've got outstanding pancreatic cancer models. I know Kay McLeod and Andrew have like KPC mice that many of them, not all of them, but some of them will develop these really intense stromal beds. And there's cancer models likewise. I know we have at UIC. So the resources in Chicago are nice if you're interested in doing that.
Okay, good to know.
Just grossly speaking, though, I mean, we have the FSA fibrosarcomas have, are very undense. And as Ina says, it looks like the MCA4s are. So that just in terms of the manipulation of the tumors, it looks like it doesn't necessarily correlate.
Thank you.
So this is Hal Swartz again. I neglected to say at the beginning that it's fantastic work and very nicely presented. One additional really important benefit as you go forward will be comparing the FMISO with the EPR oximetry. So we know that FMISO does not localize strictly according to hypoxia. We know that it has to perfuse. We know that it has to be activated by an enzyme system. We know that it has to be retained. We know that it then gets partially washed out.
Mhm.
So you have a number of really wonderful tools in with the histology and the EPR that you really could do a very important contribution to try to understand those circumstances where FMISO may actually reflect hypoxia, even though inherently it's not a very good monitor of hypoxia.
That's absolutely right. I actually have a paper in review. I hope it's still in review, where we're looking at exactly that, comparing FMISO uptake with perfusion. And we found that FMISO does have a stronger correlation with things like K-trans than EPR pO2 does. So the FMISO is definitely more affected by perfusion and everything that EPR is not.
Yeah, but
The idea behind that, Hal, is that we can perhaps use the DCE-MRI to correct the PET and to derate the absence of PET signal, and basically improves the PET signal because of changes in perfusion, and then we may be in the position to make a clinical study out of it.
Yeah, that'll be very important. One thing that you did that won't really help, and your results showed it, is just staining blood vessels won't give you a whole lot of information because the blood vessels open and close, and the density of blood vessels probably isn't the world's greatest indication of perfusion.
Right.
The other thing, hopefully, that this has showed is and that in the SCC7 models, when they're at least with the way in which we treated these animals, when the hypoxic fraction is extremely high, it becomes very difficult to select well versus hypoxic tumors to irradiate, because the hypoxia is shadowing even the well-oxygenated portions of the tumor, so that these images give you an important measure of what you can and cannot take advantage of.
Yeah. What would be really good, not now, let her get her PhD and that's the next student, would be then to look at that with methods to potentially increase the oxygen and to see if in fact you could reduce, you could in fact then get a better defined area of remaining hypoxia by simply having the animal breathe more oxygen, and whether that would localize the heterogeneity.
Repeat the archon. Yep.
Hi, this is Martyna. Ina, this was really fantastic work, and Howard, I have to say, I really appreciate the immense amount of work that went into all this. Regarding the blood vessel density, Yeah, I agree with how that it has to be functional, right? Functional vessels, and even those not always correlate with oxygenation. So with blood vessel correlation, it's very difficult. But I saw that HIF1 alpha was really excellent correlation. So that's very nice.
Yeah.
So which type of tumor was that?
That was SCC7 tumors. And for the record, it was
Okay.
really hard to stain with HIF1 alpha.
I
And
see.
it took a lot of back and
Okay.
forth of, yeah.
That's right. That's right. That's right. Yeah.
So
Okay.
if anyone needs tips, I got some. Also, actually, though, I think the company where we got our antibody of HIF1 alpha stopped making this lot.
Ah, okay.
Yeah, of course.
Yeah.
We have seen very similar in the regenerative medicine. Just because there are blood vessels seen, that doesn't mean you have higher oxygenation.
Yeah. I was expecting at least a little bit of a relationship, but it was zero. But this work has to be repeated in other tumor
Okay.
types.
Thanks.
Mhm.
Are there any more questions for Ina or for Howard or the group? I mean, very nice discussion. We've got just maybe a couple minutes if there's one more question. Well, you can breathe easy now. That was a really fantastic.
I have one question.
Oh, go ahead.
My name is Naveen Vishwakarma, and I'm a biologist at O2M Technologies, and very good work. Only I wanted to know, these tumors are like inoculated orthotopically in the leg region. These cells were injected orthotopically.
It's an intramuscular injection.
Intramuscular injection. And this EPRI, I believe, is done by using a contrast agent treadle to do in the Jiva.
Say again? Yeah, we image with the treadle, yeah.
Treadle. Okay,
Yeah.
and the treadle injection was done intratumoral, or it was like somewhere else?
It was in the tumor.
Intratumoral. Okay, thank you.
Mhm. Thank you, everyone.
No,
for-
actually, it was
Excellent.
intravenous in these experiments. It was an intravenous injection.
Oh, that's what you were. Sorry. Yeah, it was an intravenous injection that spread through the tumor.
That's the reason. Yeah, it spreads nicely. Yeah.
Yeah. Sorry.
Okay, thank you.
Okay. Thank you. Nice work, Ina. Excellent work. And thank you, Paul, for moderating this webinar. And thanks all for joining. And we're still finalizing detail for April webinar, but we'll have April, May, June. So I hope you'll tune up again next webinar, and have a good week, everyone. Bye.
Thank you.
Thank you.